anything about my hair, but I'm okay with that.
It looks great, Bridge. You're looking good, girl. There you go.
Tell us when we're ready to roll, and we'll roll.
Let's do it.
All right, it is 5 o'clock on February 24th, and I'd like to call the February Southwest Health System meeting to order. I can only imagine that we have a long list of people who have joined us on YouTube and are ready to comment. Any comments from anybody on YouTube yet that you can see, Bridget? Oh, you're muted. Still muted. There you go.
Yeah, we'll give them just a minute. They're about 10 seconds behind us.
Okay.
So I think you can start.
Okay. And if there's anyone from the public joining us, thank you for joining us. And also if there's anyone from the hospital, thanks for joining us as well. I'd like to again compliment all of the hospital staff who continue to do a great job out there. As we all know, we're a year into this. It's been a challenge, but I'm very proud of all the hard work that our staff throughout the hospital have put into making this hospital a success. So thank you very much. And again, if there are any questions from staff or from the public, you can submit them via the YouTube chat platform, and Bridget will send those our way. If you join us later on in the meeting, or if you have a question later on in the meeting before we move out of the regular meeting, we could try and answer any of those questions. That said, it looks like I think Dean joined us. Dean, do you want to jump in with your MCHD report?
Yeah, I'm here. Can you hear me? All right.
We can hear. Yep, loud and clearly. Thanks.
Okay. We are moving forward with our phase 2 with DOLA. I talked with Patrick Rondinelli yesterday. We had a meeting today, and so we're going to submit that application for the DOLA grant on Monday. So that's good news. Ralph is in the process of doing an RFP to go out to bid for that as we speak, also with the water line. So we're going to be putting an RFP out for the water irrigation line and try to get some bids back for spring work to get irrigation to the hospital on that front. Other than that, I don't think I have anything new. If anybody's got any questions for me.
Yeah, what is your time frame if you were to be awarded the DOLA dollars and then your portion of the project? How would you handle that?
You know, the DOLA grant's going to be bonus money. So we're going to still put that RFP out. I would hope we would see that RFP out by March or April, and then we would be starting work on those projects. Let me back up. We can't do any work till we get awarded a DOLA grant. So it sounds like April would be when we would be approved for the DOLA grant, somewhere in that time frame, April or May. And so we would put RFPs out and start that project in that time frame, probably in May, I would assume.
Okay. All right. That would moving pretty quickly. Okay, great.
Yeah.
Okay.
Yeah, we got preliminary pricing from Train. They put some numbers together for us to submit to DOLA. So yeah.
Okay, cool.
That's where we are.
All right. Well, sounds like good work. Thanks, Dean. Any questions for Dean? All right. I learned that if you wait 7 seconds, that's what I've learned in this platform world, that you wait 7 seconds. If no one says anything, then that's a no. So we give him
10 seconds, Tom. 10.
Oh, it's 10. We have a quick
Bridget,
group.
if Bridget says 10, it's 10.
that's for Zoom. We have a very quick group here. Okay, well, thanks, Dean. Appreciate it.
All right. Thank you, guys.
All right, we'll see you in a couple weeks.
Thanks,
Yes.
Dean.
Not
Good.
before. Okay. Bridget, doesn't look like Dan or Shirley have joined us yet. Did you get any? I didn't get anything from them. Can you confirm that they? Oh, Dan just joined us. Looks like he's here. Okay.
Yeah, I'm here, Tom.
Hey, Dan. Thanks. And don't believe Shirley is on board yet.
She is as well. We got a long list, so it's probably further down on your.
Okay. All right. Thank you. All right. Good. All right. On to CHC's report.
Thanks, Tom. This is Craig, if everybody can hear me.
Yep.
Just a couple of things I wanted to bring to the board's attention. The board report's included in your packet, but obviously we will start working on the recruitment for a new chief nursing officer for the site. This week, Laurie Breedlove started her HR conference. I think Travis was participating. I think that kicked off today, and we're doing that virtual. We continue to have our biweekly calls on the COVID CARES Act funding and documentation and analysis of the costs and lost revenues, and have provided a workbook template for reporting to CMS. We're continuing to track the frequently asked questions in that regard to see how we can utilize those funds appropriately and continue to monitor that. You know, as I mentioned last month, with the change in administration and some of the change in leadership in HHS and others, there's still some uncertainty as how they are going to progress on that, but we continue to monitor with that. Recently held a hospital-wide, a CHC-wide revenue integrity call. As you recall, first part of January, there was some new regulations that came in regards to pricing transparency and posting of that. All of the hospitals, including Southwest Health Systems, are in compliance with that, but we did have a call with our revenue cycle folks to review that just recently. Jill Bayless is with us tonight, and can speak on the update on some COVID activity, but that really concludes my report unless there's any questions that the board may have.
I don't have anything.
Do have one thing for the executive comp committee tonight in the executive session, and that's it.
Okay, good. Well, we look forward to talking to you later on. All right. Thank you. All right, let's go on to this next.
Okay, can you hear me fine?
Yes, is this Jody?
No, this is Jill Bayless.
Jill, I'm sorry.
That's okay. I'm the SVP of Clinical Services here at CHC, and I was asked to deliver a short presentation on COVID-19 vaccines and kind of where we are with CHC tonight. So I think this is my 8th one, and I have 8 more to go. So on this, let's just go to the second slide, and just a review on how vaccines work. So vaccines contain the weakened or inactive part of the particular organism that once injected, it triggers an immune system in the body. Newer vaccines may contain the blueprint for producing the antigen rather than the antigen itself. Regardless of which way the vaccine is made, the vaccine will not cause a disease, but will prompt the immune system to respond much the same way as it would to the actual pathogen. You know, I had not even, next slide, I had not even heard of an emergency use authorization, thanks Bridget, until this vaccine, but so I thought everyone might need a little update. The U.S. Food and Drug Administration is the agency that provides the regulatory advice to vaccine developers, and it follows the most rigorous scientific evaluation through all phases of the trials. And this continues even after a vaccine's been approved or authorized for EUA. So Pfizer and Moderna are now in phase 3 of the clinical trials and still being monitored. The EUA facilitates the availability and use of medical countermeasures, including vaccines, during public health emergencies. And prior to issuing an EUA, the risks and benefits are evaluated. It's an independent committee that makes recommendations to the FDA. And you may have heard on the news this morning that they will be discussing on Friday the new Johnson & Johnson vaccine and trying to make a recommendation of whether or not to, allow that to go forward and be administered. One of the newest things too related to vaccines is that they have also decided that with these new strains that they will allow the already approved vaccines to make slight modifications to cover those new strains without having to go back through the full trial. And that's kind of what they do with the flu vaccine yearly anyway. So next slide. Here's a comparison on the next slide of the COVID vaccines. There are two currently approved under the EUA, the Pfizer and the Moderna, and y'all know that. Y'all have been real active in the process. There are a few differences. Pfizer is for 16 and up, and Moderna is 18 and up. Of course, Pfizer was the first vaccine that was approved, and I think the next week Moderna was approved. They both require 2 shots. The Pfizer is 21 days apart. The Moderna is 28 days apart. The kind of difficult thing about the Pfizer vaccine is it does require sub-zero storage, and Moderna requires regular freezer storage. Side effects are the same for both, and both of them have been kind of causing enhanced side effects with those two.
So quick question, Jill. So obviously the vaccine is, they all have the same aim, whether it's Pfizer, Moderna, or now the new J&J. What is it that requires the different storage protocol in terms of freezing or sub-zero storage?
I'm not sure I can answer that question. I will tell you that Pfizer is applying to have theirs just be at regular temperature storage now. So I don't know if that's just how they did it during the first 2 phases of the trial. I wish I had that answer. I just don't know.
Okay, that's fine.
Okay. What does the vaccine look like? On the second slide, you can see the 2 different vials. For me, I'm a visual person, and when I went to get my shots, it was already drawn up in a syringe, so I didn't get to see what they look like. But here's kind of the difference in how the 2 vials look. Next slide. I'm not going to talk a lot about this, but really the transport, especially with the sub-zero freezer for the Pfizer, was no easy feat. If you see on the left, you will see the way that they had to pack that Pfizer vaccine. And then on the right, you can see a conveyor belt with all these different cartons of doses of vaccines that are loaded out the end of that conveyor belt into that sub-zero freezer, which is in the top slide. And then that freezer is loaded onto the jet. So it's really pretty complicated, and I'm sure they would much prefer, regular freezer temperature. And I actually just heard that this morning, so I haven't heard more about it. Where we are on the vaccinations now, on the next slide, Johnson & Johnson is seeking their EUA. 1/10 of all eligible adults have had 1 shot. Almost 3% have been fully vaccinated with 2 shots. And our goal is 70% to have herd immunity. So we have a little ways to go yet. One little other thing that I did look up, in all the CHC states where we have hospitals, I have the percent of eligible adults who've had 1 vaccination. I'm just going to tell you those. Texas is 9%, Kansas 7.9%, Colorado 9.2%, Louisiana 9.3%, New Mexico, they're actually really leading the pack at 11.7%, and Hawaii at 9.7%. On this slide, this is blinded, so it's all the CHC hospitals that I had the information of. This was as of February 2nd. So if you'll look at it, the red bars are the Pfizer vaccine, the blue bars are the Moderna vaccine, the yellow bar is a facility that actually received both. On this graph, you are looking really good. You are hospital L. And so this is your hospital vaccination rate. It doesn't include your clinics. This is your hospital employee vaccination rate. So that's really good. You are tied for second. The first place, the 89%, was at a very, very small hospital that we have in New Mexico. And then that lowest one that you see at 16% is a very, very small hospital in kind of central Texas. So I did not have permission from all of them to put their names. So I'm just really kind of calling out which one you are. So congratulations, y'all did really well. And I heard a lot about how you did your process, and it sounded excellent. So just a reminder about what herd immunity is, and I mean, you probably know, but I'm just going to read it off. When a lot of people within a community are vaccinated, the pathogen has a hard time circulating because most of the people that the pathogen encounters are immune. The more people that are vaccinated, the less likely that people who were unable to get the vaccination and be protected by vaccines are at risk for being exposed. With herd immunity, the unvaccinated would have substantial protection because the people around them were vaccinated. On the next slide, it's just what's next. Again, the Johnson & Johnson vaccine, super sites in large metropolitan areas. There are supposed to be 100 of these across the United States that in large metropolitan areas. They'll be open 7 days a week for 8 weeks, 6,000 shots per day. My understanding is the military will be leading this initiative, but my guess is that they'll be soliciting some help in all of those different super sites when they get ready to do it. Don't quit yet. We're not quite there. You know, we're still recommending masks 6 feet apart, social distancing. And when you are able, based on your state's guidelines, get the vaccination. And finally, I have a list of frequently asked questions that have come up with CHC, and I'm not going to read them all to you because you can do that yourself. But I would like to say that CHC facilities didn't get to pick which vaccine they wanted, that most of them have very little notice as to when they would receive the vaccines, especially early on. So some of them were notified 1 day prior to receiving their vaccine. And they received vaccines, all of our facilities, between week 1 and week 6 of the vaccination release. We are currently in week 11, so all of our facilities have received some vaccine. We did have one that was kind of delayed to week 6, but they had a hospital kind of maybe about 50 miles away who shared some of their vaccine with them until they got their own. Most CHC facilities did not become hubs, and really they chose not to because their real focus was on the inpatient COVID patient. But all of our facilities were very active in the administration and vaccination of their community, and y'all were leading the pack on that. So thank you for doing that. I mean, I think this whole process of COVID-19 has stretched us all and has shown what we're capable of, and maybe what we don't want to have to do again. But thank you for what you did. All hospital employees were able to obtain the vaccine if they were willing to take it. Not one facility reported that they didn't have enough vaccine to give their employees if they wanted to have it. All state guidelines were a little bit different in who could get that vaccine. It was prioritized very differently. So, you know, when you're talking to your mom in Texas, that's going to be different than how it was in Colorado. And what were some of the reasons for the staff gave for not wanting to take the vaccine? And I'll tell you, this was the most frequent question on this list. And here are some of the answers. They were pregnant, or they were going to try to get pregnant. They were lactating. They had immune issues or allergies. Some of them just wanted to wait and see how other people did. Some didn't feel good about it, you know, while it's still under an EUA on that 3rd phase of the clinical trial. And then others just didn't give a reason. We didn't require a reason, but some people just volunteered that. So that's really my whole presentation. If you have any questions, I will wait the 10 seconds and then I can drop off. I'm happy to entertain any questions that I might be able to answer.
No, that's great. I'd actually like to, if you could email that, and I think it's part of our broader package, but I would like to get that PowerPoint emailed to us, separate from the package, just because it would be something that we could pass on to others.
Yeah, we can sure do that. Bridget, will you do that, or would you like me to?
I got it, no problem.
Okay, all right.
Thank you.
Thank you so much. Thanks for letting me speak. Any other questions? Okay, thanks a lot.
Thanks, Jill. All right, have a good time or good evening. Thanks. All right, anything else with CHC before we move on? Craig, or you got anything else for us?
No, not at this time, Tom. Thank you, though.
Thank you. All right, on to you, Tony.
All right, just a couple things. In your package, you've got a copy of our current or our revised organizational chart. When Karen left, we basically divvied up her departments to different areas, and Rick and Carrie took on the majority of those. I did pick up a couple, being sleep lab and diagnostic imaging. And but just wanted to let you know where we were with that right now. So unless anyone has any questions about that. If not, just a couple other things. I mentioned sleep lab. We are actually in the process of remodeling the old ICU on the second floor and actually are turning that into the sleep center. So we're going to move the sleep center out of where it's at now in the kind of close to where the administrative area is. And we'll be, I think we're going to end up with a really nice center there. And when we get it all done. So Rob's been coordinating that and working with Lindsay to get that done. And so we'll get that moving forward, and hopefully in the next couple of months or so have that center moved from where it is now. Just another thing, let you know.
Quick question.
Yeah,
Quick question, just to go back to that second floor. So if MCHD gets funds to do work with, my understanding is that they would also do some work, or they would do some work on that second floor. Would that require the sleep lab to move again, or how does that work?
Yeah, they mentioned that about doing the second floor, and you know, my comment at this point is I'm not sure that's where our priority is.
Okay.
I talked to Dean about that a little bit and said we really need to analyze that because we're actually utilizing that floor pretty well right now. And I actually think there may be a different direction that the funds could go if we get that, get that far on that. So we'd have to analyze that. That would be potential if they did decide to do everything that originally had been planned to that second floor, that it would. But we're actually not. It's not going to be a big investment to get the sleep lab moved, so it wouldn't be terrible if we had to do that. We're not sinking a lot of money into it to do that. So.
Okay, thank you.
All right. We are working with the Ute Mountain Tribe. Actually, I think some of them started today, but they're trying to get their casino reopened. And so we're going to be doing some testing for their staff. I think we're planning on doing about 150 tests tomorrow out at the casino. And so we're going to help them get that and try to get that back up and running. So other than that, I think that's about all I have right now. There's some other things to discuss in executive, but that's all I have for this session.
Okay, any questions? All righty. Well, let's move on to quality.
Hello, everyone. I just wanted to really follow up again on our final DNV survey. Last I talked to you, we were waiting for that final write-up and corrective action plan. You can go to the next slide, Bridget. DNV did come back with approval of all of the action plans we wrote up, and they did issue our 3-year accreditation for 2021 through 2024. So glad to have that documented. It's very important for us to show payers that we are doing what we need to do and maintaining that accreditation. And DNV still continues yearly surveys for us, so that will continue each year until we have that 3-year recertification again in 2024. However, I don't know if it will be virtual again. I have been asked for feedback on how well it went, how we did. So I do see that those virtual platforms may continue with our regulatory agencies. Another win for us, I talked about where we were in improvement projects with sepsis this year as well. Q4, we were only at 27% of where we needed to look for abstractions for CMS, which is a long list of metrics that goes into our sepsis patients. But just for January, we've increased to 60% capture of meeting that measure, which is a significant improvement over a small time frame. I do want to do a shout out to the staff and emergency department, the inpatient departments for really taking that on and being diligent. I know they've really pushed that to the providers and been a little bit more active to meet everything. What we are falling out on is a second lab draw, which is very minor. So I don't want these numbers to be concerning as far as, you know, what we're doing with our patients. It really is coming down to all of the metrics that CMS is asking for. So we are doing really well. We're identifying the patients. They are getting their early antibiotics, their early lab draws, their early fluid intake. So really, this is still not great of an indicator of what's happening, but, you know, ultimately it is reported to CMS, and that is an improvement project. So sharing those results. So I hope to see this move forward. I have more education this year, like I did last year, to push out still. So obviously this is still, you know, an ongoing improvement project. I did want to share, we were really excited last year when our facility star rating was at a 4. Unfortunately, I was notified with CMS that it was decreased to a 3. I've been talking to other hospitals. Obviously, this is, you know, not, you know, we're in the boat with a lot of other hospitals with this because of our patient satisfaction with COVID, as far as, you know, without visitors, without, you know, all of us are in masks. It's been a different time this year, and each quarter, you know, we've consistently been lower on where we would like to see with our HCAHPS, with our inpatient surveys for sure. So this breakdown is really what Q4 was. Would recommend hospital is at 61%, but our percentile ranking is at 14. So, you know, really a significant decrease. Q3, where our percentile rank was at 41. What's sad is, you know, individual like communication with doctors is above average. Our response rate is above average. But at the end of the day, our overall rating is still at a 66, where average is 71. So action plans to improve this are already taking place. Look forward to showing you what that really looks like in the forward. The directors are pulling together to really make that improvement plan for patient satisfaction, so that when they leave, you know, that overall rating of the hospital is really showing what we're doing with our patients. And then I talked about the quality improvement plan last month. Hopefully you guys have filled out the surveys as far as 2020 for the quality program and sent those to Bridget. That would be great. If you haven't, go ahead and fill those out for me. I would really like feedback, or, you know, specific information that you feel like needs to be shared from me. But if you can look at that plan and approve that for this year, that would be great. And that is my spiel. Any questions?
I don't have anything. I think we still need some folks to provide that document, or provide comments to Lisa. I know that it was I did it, and it was a little difficult for me to understand because I'm not in the role that everybody else is. But if those who have not filled that out could do that, and Lisa, if people have questions, I think it would be best that they get in touch with you.
Great.
Okay. All right. Anything else for Lisa?
I think she's got a report in here too.
What was that? Sorry, Bridget, I lost you.
Lisa, didn't we have one more thing? Yeah, the quality plan, right?
Mm-hmm. And this plan is, you know, really how we're integrated as, you know, a facility with quality. It really speaks to how all of the different councils, entities pull back into, you know, the whole facility-wide quality improvement plan. So hopefully you had a chance to read that, and, you know, if you have any questions, let me know. But it's really how we pull it together, what we do with the metrics, and, you know, how we feed that back information-wise.
Okay.
Lisa, do you need a board action on this item?
I do need an approval for the board, yes.
Thank you.
Okay. Only for the the quality improvement plan, correct?
Correct.
That's
Yeah.
correct.
Good. All right. Do we hear, if there are any questions first? Don't believe so. All right. Do I hear a motion to approve the 2021 quality improvement plan?
I so move.
I'll
And
second.
then second by Cody. All those in favor?
Aye.
Any opposed? None. All right. So move. Okay. Lisa, thank you.
Thanks,
Thank
Lisa.
you.
Well done. All right. Let's move on. Carrie, it's all yours.
Great. Again, thank you, Lisa. She's worked so hard on the quality improvement plan, as well as immediately jumping onto the Medicare star rating. So that's really important for us as an organization to maintain our star rating and to strive for that 5 stars. Obviously, being a 4-star in COVID is extremely difficult based on just exactly what Lisa said, the visitor restrictions, and that does have a huge impact on patient satisfaction. Some of the hospital side updates, we have Shauna, I can never pronounce her last name, but it's like Shilikis, somebody else. Starts on March 1st. She is the new outpatient services coordinator. So she is going to oversee ER and OR. So we're really excited to get those programs kind of under one director and have the ability to allow them to grow and utilize the resources fully. That includes Aaron and Jamie, who have been in the OR for a very long time, who are really great with patients. And so allowing them to provide some more face-to-face patient time, as well as Bernie Page in the ER. So I feel like it's a really great move, and we're really excited to see how this rolls out next week. Another new director that is coming on is Thad Harlow. He is starting on March 15th. He is the PT rehab services, so OT, PT, speech language pathologist, supervisor, director for that area. Really excited to work with him as well. He brings a plethora of experience and excited to look at different ways to approach PT in our organization. News from the side of the hospital in general, OB is looking to transition back to the new area, or our old new area. So the new part of the building on March 1st, so on Monday, pending any women in labor. So if someone's in labor, we're not going to move the department. At that same day on March 1st, there will be a lift on the visitor restrictions. So we will provide guidelines on what visitors look like to the hospital, but you will see the visitor restriction signs come down and kind of open up a little bit and allow a little bit more freedom in the people who are allowed to visit the hospital.
Mechanism, Carrie kicked that in. Is that state guidance under the governor's orders, or is that done in-house?
That is done in-house. And so we made the decision as a leadership team, and Tony really took the lead on that with looking at the numbers, the trending numbers in the community, and then assess the current situation, and really being a huge factor in patient satisfaction, but also the fact that we are so safe with the amount of social distancing we're providing in-house, the mask, the monitoring at the front. We're pretty much doing everything you could do in the community, and even bring it to another level of monitoring who's coming in the building. So it's not so much about allowing 10 visitors in with one patient, but allowing their significant other to attend clinic appointments and to be a part of their care is so important that we felt like that outweighed the risk at this point. The next part, big news part on the hospital side is Lisa has been working hard on the hospital transformation project application. So it's in its final stages. And again, thank you, Lisa. Huge project, huge benefits for our organization and for our community and our patient care. So really looking forward to work through that over the next 6 months. I think Tony already talked about sleep lab moving. We are in the process of reviewing some ED visit volume and monitoring current staffing and making sure that we are providing, the amount of providers and care, nurses and support staff to treat the community. We are again reviewing OR volume in the same way and looking at the future state of the OR, knowing that we have a lot of new providers coming on in 2021 who are surgeons. So we are looking at ways to utilize block time and what that will look like, knowing with all these the additional surgeons coming on. So huge benefit for this community as we're bringing in some really great qualified and experienced providers. And so doing that and also allowing some time in the OR for them is a challenge, but we are going to make that happen. I know Joe Vallis talked a lot about the vaccine, so I'm just going to touch really quick. I know Tony probably has a lot more to talk about the vaccine at some point, probably an executive, but we do have the vaccine clinic in full swing. We brought on a scheduling program this week that will help us to be able to schedule online. Well, I'm sorry, it'll help patients be able to schedule online for their vaccine. It's very similar to making an appointment at a doctor's office where you go in, you pick your day. We have a certain amount of slots available, your time slot, you pick it, you put your name, your phone number. It sends you email and text updates and provides you reminders. So I think it's pretty awesome. They just started using it today. They are using it for their first time with a clinic on Monday, I believe. And so in the next 2 weeks, we'll roll that out full swing to all clinics and second doses. So that will help with the pressure that we have with vaccinating, over 20,000 people likely.
Does that program ask for information that allows you all to make a decision that that person fits the 1A or 1B designation, or how do we suss that all out to make sure
Yeah, it's pretty amazing. So this program it's called RSVPify. It is, and I'm not plugging them, but it's really amazing that it's an event scheduling program that as soon as COVID hit with the vaccination, knowing that it was going to roll out, they kind of rolled out a HIPAA compliant, but also secure information portal that allows people to enter their name, their date of birth, and then sorts it into categories where you qualify, you don't qualify. And if you don't qualify at this time, it puts you in a waiting list. And we're able to look at that waiting list and pull from that waiting list, even on the day of the clinic, if we have extra doses for people that didn't show up. So huge benefit for us and for the community, and a big thank you to Lindsay Yeager for taking that on and really pushing through the pieces there. It's been a very difficult manual process up until now, and I feel like this will kind of tie up any loose ends that were out there in the community and hopefully capture anyone that we've missed at this point.
Cool. Sounds neat.
Okay, a couple other things on the medical group side. We have a general surgeon that just joined our on-call rotation. Her name is Eve Bruno. She works in Shiprock, and we are really excited to welcome her to our on-call team, providing emergency care after hours. So that'll help support our current general surgeons and also allow for additional patients to be seen and treated here in the community. So that's always our priority. And she's definitely going to be a great addition to the team. During the last month, we have offered to an FNP who accepted a position to do pulmonary and family medicine. Obviously, pulmonary, we have about a 2 to 3 month wait right now to get in with our pulmonologist. So providing some support there, especially post-COVID, and making sure that we can take care of patients and have them seen in a timely manner was a priority for us. So she will be starting hopefully here in the next month or two. We also have a letter of intent out to an OBGYN who will provide 10 days of month coverage on call as well as in clinic. So that's a huge benefit. He brings over 20 years of experience with him. So again, we're recruiting really experienced or really brand new fresh residents who are happy and excited to treat patients and are trained to the best extent. So really excited about them. And our last update for this month on recruiting is we have a OBGYN and hospitalist family medicine doc, both coming to visit on March 19th. So more to come in the future on those. Excuse me. few last updates regarding the clinics. The provider newsletter went out this month, so it was really well received. It was a general statement from, or a personalized statement from each of the senior leadership team, as well as, let me think who else. I think the senior leadership team at this point. We did have some recommendations about how to change that or alter the format a little bit. So we will be adjusting that coming this month. Allowing a spot for kind of a provider spotlight so the providers can get to know each other better. And I think that was one of our huge wins. The last thing that I'd like to share with especially our public is that we've seen clinic visits in January were about 3,800 visits for the month. Prior year, so last year, which was pre-COVID, we had about 4,000 visits. So we're almost where we were last year. So it's good to see that our community is coming back. They're getting their health care. They're doing the things that they need to do to follow up with their specialists, to follow up with their primary care physicians and providers, and we're able to take care of them. So very happy for that. That's all that I have.
I mean, the recruiting continues to be great news every month. And, I know we did, we had an article in the paper, the interview of, I can't remember the new physician who was interviewed in the paper, and it was a great article. And I've rattled Jim Mimiaga a few times saying, hey, let's do an article about how well we're rolling out all of this vaccination, because, we're really knocking it out of the park. And I think that would help the hospital from a PR perspective too. And I think it'd be nice to try and rattle the paper's cages a little bit more and have them do an article on how good recruiting is going, because it's really filling that gap. It's eliminated that wait list that we have out there, and so I think I'll try and rattle Jim Mimiaga's cage a little bit more, and have them reach out to Tony or to Carrie or whomever, Bridget, all of you, just so we can really start to highlight how well the hospital is doing in this damn-pemic, this era of a damn-pemic, and get some more good PR to the hospital. But great job bringing in a deep bench.
Thank you. I'm really actually excited. And you said the key word there for, I think, our whole community is we're filling the gap. And so there has been a gap in this community, a gap in care in this community for a very long time. And so I do feel like we were extremely blessed this past year to bring in really quality providers, to get to see those patients, to take care of that wait list, and also to roll out a vaccine and testing protocol faster than anyone in the Four Corners. So we've been really agile during COVID, and I think I agree with you. It's time we get a little bit of recognition for that.
Yeah. I don't want to place an ad. I want an article.
Right.
And maybe we'll spell check it and fact check
exactly.
or at least fact check it. So, all right. Well, good job. Okay, Carrie, anything else? Oh, I did have a question for you, Carrie. So maybe we can talk about this later, but the rural health clinic policies, now, thank you for explaining it to us, to me last night. And Susan, I think you're already on that. I'd be happy. I know that you needed someone from the community, Carrie, and if you need me to fill that gap, I can do that.
I do have, I actually was really lucky to have Sharon Martinez, who is now the school nurse at the Manka School District, has volunteered to do that, but we are happy to take any more community members always, to take a look at our policies, to make suggestions, and to fill in anything that we may be missing. So happy to have somebody else join if you have someone who's interested.
Well, I'll be happy to review those and then join you. I don't know if we can do it on St. Patty's Day, but
sorry.
That's okay. I don't know if I can make that, but we'll talk.
That sounds good. No problem.
Okay. Thanks, Carrie.
Thank you.
All right, Rick, the stage is yours, man. But you have to mute.
Thanks. It's hard to follow Tony and Lisa and Carrie, but we'll go ahead and give it a shot. So again, in your packets, you guys can take a look, and we'll kind of go through the financial narrative. Again, we started off the month we started off 2021 very well. We had strong patient cash collections of over $4.6 million for January. We did receive $406,000 as a result of our interim cost report that we did. And basically, we do a 6-month cost report to see where we'll be plus or minus by the end of the year and kind of do some projections. Our friends at HRP that Todd Beasley from CHC introduced us to are doing did a fine job on that. So we did get that money in first week of January. We did have operating cash decrease by about $600,000 from December. And that's through paying out some of our accounts payable. Plus we had a bunch of dues for the Colorado Hospital Association, Western Health Alliance, and a few other things that come due at the beginning of the year. Combined investments again showed a market loss of $9,000. Gross AR, however, did increase by 1.3, and our net increased by about slightly under $700,000. Non-patient AR was fairly well flat, but did show a $12,000 decrease. Inventory was flat. Prepaid expenses, again, these are some of the amortizations of contracts, did decrease by about $26,000. And long-term investments showed a slight gain of about $1,000. Fixed assets decreased by $366,000, primarily as a result of depreciation, and then a few assets that we purchased. So our asset performance fairly strong. Again, accounts payable did decrease by about $504,000. Payroll liabilities did increase slightly by about $226,000. That's based on our accrual. Accrued other current liabilities did increase $183,000 due to the settlement receipt we got on the interim cost report, and some accrued health claims, bonuses, and other miscellaneous liability transactions. Again, we did change our health plan in 2021. I think Travis will cover that. And just giving you guys kind of a quick update. We're still self-insured up to $200,000 with reinsurance kicking in at just over $200,000. Revenue over expenses for January, we showed a slight loss of $45,000. That's operating loss. But our EBITDA was strong at $484,000. From an income statement standpoint, gross patient revenue above budget by $446,000. Net patient revenue was above by $314,000. We had strong performance in the clinics, where clinic revenues were above budget by $107,000. Our inpatient, we did see strong gains in inpatient as well as outpatient. So total net revenue, all things included, was about $285,000. And that includes some of our other operating revenues. Provider salaries above budget by about $92,000. Staff salaries were above budget by about $43,000. We did, if you're comparing the 2021 numbers to 2020, we had over accrued some salaries in December of 19, which reversed out December of 2020. All other things being equal. Provider salaries budget for January, slight miss on my part. However, it's rectified through the rest of the year, so we shouldn't have any issues unless we bring some unbudgeted providers onto our team. We are working with CHC on doing a more robust productivity system. Some of the things that we saw after we approved the budget that were kind of excluded were things around the way of a vaccine clinic. So we got vaccine clinic in there, so that was somewhat of an unbudgeted department. Again, the vaccine's free. However, we do need the staff to provide the vaccine to our Montezuma County residents, as well as monitor them for any side effects. Contract labor did total about $256,000. So it included us, plus we contracted with some nurses that could give the shots. Medical specialist fees were about $68,000 below budget. and that's based on some of the providers that they either outsource or serving on committees. Purchase services slightly above budget by about 47,000, and a lot of things we had been outsourcing. So we'd seen a pretty big uptick in our outsourcing to Quest. A lot of that was COVID. Plus, we weren't getting as many BD Max samples or test kits for allocation as we had been in the past. Those things are changing. We're going to go ahead and get some more kits so we can send less stuff out to Quest. We can do it exponentially more cost effective if we don't have to send it out. Salaries above budget, 140,000 due to, again, we're continuing to, our orthopods are doing a lot of joint replacements, and those are shoulder joints, knee joints, and hip joints run anywhere from $8,000 to slightly over 10. Retail prescriptions, we hit another record. So we do have Mark hates the term retail pharmacy. Mark calls it an outpatient pharmacy. So we do have a pharmacy that's tied into a clinic that fills prescriptions for our Montezuma County population as well as our clinic patients. Although there's supply items, they look within the plus or minus 5% of budget, which was not unreasonable. Rents, leases, utilities on par with budget. We did have interest expense of $138,000, which is the bond payment plus the Olympic Scopes lease. Depreciation, again, we talked about it, $391,000. Fell within the normal range of things. Donations was part of the sales tax that was based on our behalf to help take out some of the bond payment. Ladies and gentlemen, any questions on the balance sheet, income statement, or the narrative? Okay. Thank God I was not muted. If you're looking on page 42, we have our Zion debt service account schedule. Again, you guys can see the sales tax plus what we paid out of operations on the bond payments. Next page, we have our daily cash on hand. We are at 87 days for January, and we're going to be between somewhere around 88 days in February. That's our projection as of now, assuming cash comes in the way we think it will on Thursday and Friday. Page 44 is our statistics page. As we kind of referenced in the past or earlier, we had strong clinic visits. That's kind of midway down the page. ED visits, slightly backing off. That's, discussing it in the senior team. We're thinking that we have more providers that can see patients, which we believe requires them to go to the emergency department a little bit less. So we did see we are seeing our expected admissions, inpatient admissions that are coming through our emergency department. Surgery, again, fairly strong for the month of December. We had 20 business days, so we did about 166 cases all in. Again, therapies, again, strong from that standpoint. Infusion down a little bit. Mostly that's due to, again, some of the weekdays from our infusion departments. We do anywhere from chemo to antibiotics and things like that. As you guys can see, our lab test, again, 12,750, which is up considerably from budget and from prior year. We thought we'd have maybe a few less lab tests, but again, we exceeded budget. Page 45 is our ratios, our operational analysis. As you guys can see, we have things that are strong with our return on assets, asset test ratios. Again, the big one is days cash on hand, where we're at 87 days. Debt service coverage ratios fall within the metrics. And what we've tried to do to make this easier to read is give previous quarters plus current months activities. Any questions on the ratios of days cash on hand? Okay. I counted to 7, I think, Tom. Sources and uses of funds. This is where our activities go, our intake and our our output again, and that foots to 87 days. Our report card is page 47, where we are with our business office elements. Team's doing a strong job. Hospital and clinics. Indicator 1, our hospital is about, we're hitting our target, or exceeding our targets. Our clinic days are about 2, but again, our cash that we're doing rolling 12 months compared to net revenue is doing well. Our AR days are way below the goals, and our credit balances are, we should have those by 3% probably within the next couple of months. So if you aggregate it out, we're probably at about 5% credit balances, which is not bad, but we're going to get it down to less than 3 here in the next few months. Ladies, gentlemen, any questions on the financial packet?
None.
Okay. One of the other things that I need to tell you, our auditors, Blue and Company, they were there last week. There's not a lot of, there's a couple things that we're discussing. No material adjustments. The financials are going to be pretty close to where they were in December, if not a little bit better. Looking at some of the allowances and some of the things they're asking questions about. Because 2020 was an interesting year, to say the least, and because we participated in the payroll protection plan and other CARES Act money with HHS stimulus, we are required to undergo a GASB audit, which is under governmental auditing standards. That is rare for us. We are not a governmental entity. We're a 501c3 that has a lease with a governmental entity, which is MCHD. Because we did participate in those grant programs, Blue and Company is going to come back later this spring, early this summer, to go ahead and do a GASB audit. It will be looking at our internal control processes, things like that. And that is going to cost us an additional $25,000, which probably for the audit and maybe a few thousand in expenses. They said it's covered by the CARES Act, but if you spend all your CARES Act money, then you're probably just out of pocket. So wanted to give you guys a heads up. I know Steve talked about it to the finance committee. However, he wanted me to let you guys know what the cost would be.
Okay.
So Dan, Tom, Shirley, Cody, Susan, that's my financial report with the basically, I think we need resolutions to approve the financials as presented, plus a resolution to sign an engagement letter with Blue and Company to perform our single audit based on our participating in governmental programs. Mr. Birch, please correct me if I misspoke.
You're good.
When I sat down, I took my abacus and I sat down with Blue and Company to help them do some, some of their work, but they didn't know what it was, nor a slide rule. But anyway, they were very, they were very complimentary of the work that's been being done. So kudos to Rick and his crew, as well as the finance committee too.
Yeah,
they're playing an important role. So
yeah, thank you guys. We did. Tony and I, and we discussed it in senior leadership. We decided to promote Heather Frazier, who's an integral part of our team, from accounting director to controller. So just giving you guys a heads up on that too.
Does she really want to do that?
She'll kill me for this, but hey, let's leave it out in perpetuity. She has somewhat of a controlling personality, so the title fits.
Rick, they wouldn't call me a controller. They called me a comptroller because they knew I wanted to control and they wouldn't let me have it.
I found sometimes it's okay to acquiesce as I'm getting older.
Shirley, we'll give you we'll give you a card, Shirley, that says controller on it.
I made my own cards that said controller on it.
Good. Good.
And I hand it out to the people that need to know.
Gotcha.
Well done.
I still have my cards that say interim CFO because, Tom, as you've reminded me, even if you're permanent, you're still an interim.
We all are. We all are.
Yep.
Yep. Well, good job. I'm glad you're here and not interim.
Thank you. Good to be here.
Yeah. Okay. Any more questions for Rick, the comptroller, or not the comptroller, but Rick? Okay. We need to make. I do need to hear if we have a motion to approve the January financials as recommended. Okay. Is there a second?
I second.
Okay. All those in favor?
Aye.
Aye.
Okay. All right. Anything else for Rick?
Tom,
Okay.
if you guys could entertain a motion that we could sign an engagement letter with Blue and Company for the single audit, the Gatsby audit.
The Great Gatsby? The Great Gatsby
Yes, sir.
audit? Okay, good. Do I hear a motion to enter an agreement with Blue and Company to complete a Gatsby audit?
So moved.
Second.
All those in favor?
Aye.
And do we, I mean, 25 grand in the grand scheme of things isn't a ton of money, but do we want to earmark any of that COVID funding, CARES Act funding for that, or is that just not necessary?
It kind of depends. I mean, there are some things that we've got going with our friends at Train where we can do some capital projects. The other piece of the equation is if there's money left, we'll definitely do it. We also have the vaccine clinic, and Bridget and I are working on the FEMA application for the people that are giving the vaccines. But if FEMA doesn't cover it, that may fall under COVID. The other thing is we're still kind of easing through the pandemic. We can still capture COVID expenses to apply against that money, plus any kind of lost revenue. Right now, we're thinking, and again, we're thinking that we will have about $1.1 million to $1.2 million, roughly. And again, we should have a couple of final numbers from the auditors here, probably towards the end of next week, of monies that will be unused for HHS stimulus. So yes. But Tom, like I said, in the next 6 months, depending on how things roll, I have no idea if we'll be using that as an offset to revenue or not.
Okay, not a big deal. I know we're good for it. I know we got to do it anyway, so that's that. So, okay, great. Anything else here for Rick?
Tom,
Go ahead,
I
John.
would recommend that you approve the CHC voucher that we had recommended in finance.
Thank you. Do I hear a motion to approve the CHC invoice as recommended?
So move.
And is there a second?
Second.
All those in favor?
Aye.
Okay, none opposed. All right. Let's move on to the approval of the January minutes, board minutes. Do I hear a motion to approve the January minutes?
So moved.
Second.
Shirley, Dan, second. All those in favor?
Aye.
Okay. All those, any opposed to it? None? All right. Okay. Anything else before we adjourn to our executive session? Okay, it's 6:05. We're going to adjourn to our executive session. And for those who are not going to join us, thanks for all your hard work. Anybody who is watching on YouTube, thanks for joining us. Certainly, if anyone has any comments, they can be emailed to Shirley. I'm sorry, to Bridget, and those can be passed on.